Good morning, Tom. Welcome to another podcast. How are you?
Very well, thanks, Stephen. How about yourself?
I'm very well, thanks, Tom. I'd like you to introduce yourself and tell people exactly how you ended up where you are today, please.
Oh, it's a good question. I'm Tom, based up in Manchester. So how did I get to where I am? I studied over in the States, cardiac physiology alongside being on a football scholarship. 4 years up in the depths of North Dakota of all places. So an interesting start to adulthood for me. Came back to the UK with the ambition of taking a role within cardiac rehabilitation. Did a couple of different voluntary internships, John Ratcliffe and Horton hospitals. But I was actually based in Northampton at the time, so my first kind of foray into digital health was based on the fact that I couldn't. Within those voluntary roles, I couldn't actually fund getting to the internship. So moved out of clinical practice quite quickly into a job with AXA in the private sector as a physiologist, initially delivering on-site wellbeing, at testing, screening, moving into a number of different roles there, but ending up managing and creating and evaluating wellbeing programs for large corporates in AXA's private medical insurance portfolio. 4 years there before moving across to Lever Healthcare, so a small Danish startup that were essentially a digital coaching company, had a partnership with AXA that's still ongoing. But the role there was essentially to support an early pilot that they'd got for delivering a coaching service to the NHS, also building out a coaching service internally at Lever, whereas previously they'd just outsourced that function. So overseeing kind of all of the clinical services and service delivery. Back end of that role was more focused on business development and sales. It was my first kind of real foray into sales, looking at our ventures with Novo Nordisk and Lloyd's Pharmacy. So we were looking at medicated weight management programs, combining the digital coaching solution for patients who were taking Saxenda at the time. So it was a really interesting kind of insight into what that medicated weight management setup could look like, which has, of course, most recently been quite widely approved and adopted through NHS England. After 4 years there, of which a year of that was in Copenhagen, I moved back to the UK to head up business development for Lever. A little bit short-lived, that role in terms of some of the company mechanics. I moved on quite quickly to a role with Orca, so Organisation for the Review and Accreditation of Health and Apps. Again, a business development and sales role, with quite a big focus on pharma collaboration. Quite a lot of time spent in the US as well, and I think probably a little bit before our time in terms of the product and the value proposition. So quite a short-lived role there, which leads me to where I am now, which is account director and head of new business and partnerships for Quiddity Health. We're a commercial accelerator, supported more than 80 companies in the health tech and medtech space to date. Current portfolio of about 30. My own role is a portfolio of a couple of companies that I'm owning the commercial strategy and deliverables for, as well as looking at all of our new business and partnership opportunities. So what kind of new exciting digital medtech companies do we want to work with that we feel have the best opportunity for success? As well as scoping different partnerships with the likes of the Health Innovation Networks, Department of Business and Trade, health tech hubs across Europe and the rest of the world, to essentially look at how we can support from a commercialization point of view, with the UK market primarily in mind.
Okay, so for the digital apps that are watching this podcast, how do they get, how does a digital app get reimbursed, or how does it commercialize in the NHS?
Yeah, there's various different routes in. So we have national frameworks and tenders and large scale opportunities. But I think the entry point for most of those products comes through direct engagement. Digital is such a broad subject in terms of what that entails. You can be commissioned directly. There are independent budget responsibilities with GP practices or primary care networks, which are generally independently run businesses. It can be independently with hospitals and trusts being groups of hospitals essentially, or it can be larger scale within the integrated care systems and boards, the ICSs or the ICBs. But we often focus on direct engagement. There are different pockets of funding that exist. So HTAF funding, health technology adoption, is one that sits quite prominently. Lots of the trusts have charitable funds that exist. So there's not a kind of one size, one answer fits all. I guess it depends on the backdrop of the company, the evidence base they have. Are they coming at the UK on the back of, really strong home market success, or is the UK the first market that they're looking to build into and expand through? They'll all kind of have impacts on the strategy and the direction of travel for anything classed as digital or kind of software or medtech.
Okay, so tell me something about the NHS supply chain and its frameworks. I know that there's the NHS app library. I know there's NHS X Digital Health Playbook, and there's the G Cloud.
Crikey, where do we start with those? I think if we look at the NHS app library, historically that was built out to be an access point for digital technologies. The reality of engagement through that has been very limited. So I think in terms of a start point, particularly for reimbursement, there are various challenges around that probably don't make it a particularly good start point. G Cloud we always recommend as a really good way of evaluating where you're at as a business with regards to UK market entry. There are quite strict requirements in terms of regulatory, the nature of your business, financials, being able to effectively define what your service is, what you're offering to who, what the variations of service, what the pricing models that you're willing to commit to, because once in G Cloud, you can't diversify from that too much. So we tend to say G Cloud as a kind of lay of the land in terms of where you're at is really good. Plus, it only opens in cycles. So the most recent iteration is G Cloud 14. If you're not a part of that, you're potentially going to have to wait 12 months before the next window opens for you to be a part of it. Now, ironically, depending on what type of solution you are, the commercialization through G Cloud is not necessarily the point of going onto it. We have a number of our clients who have gone on to G Cloud from a credibility perspective to have that kind of stamp of approval in terms of you're able to work with the public sector, but the actual revenue attainment through G Cloud is zero. For companies that their ARR is in the hundreds of thousands of millions. So I would say it's, again, the point of going onto those types of frameworks needs to be quite clear. Often companies say to me, we need to get onto G Cloud because that's where we're going to make our money. And for a lot of the early stage companies, that's not necessarily true. And equally with things like the shared business service framework, there are some mature channels and companies that are very well reimbursed through that framework. There are companies that are on there that haven't made a penny. And again, the point of being on there is purely from a visibility point of view, but the funding channels they're accessing are not necessarily through that historical pathway. So it's important to know what the role of each of those frameworks and opportunities is in relation to credibility, but also commercialization, which of course are very different.
Okay, so what about direct commissioning in the NHS, the ICB reimbursement, the NHS Innovation Accelerators, and the NHS test beds? What can you tell me about those?
Yeah, again, so if we pick them apart individually, for companies to go directly to ICBs and be funded as a first point of call is quite rare. You're generally going to have some evidence, so of course the right regulatory things in place. An ICB might be a good start point in terms of perhaps selecting a hospital in a trust in an ICB, and that being your kind of first use case that you can then kind of expand out of. But broad commissioning of a solution across an ICB in the early stages of an organization's journey is quite rare. That isn't something that we see often. Generally, a good route into that type of engagement might be the grant landscape. So I think the UK remains the best place in the world for grants and early stage funding and support with the likes of Innovate UK, SBRI, and there are lots of others that kind of sit within that. And often what will be part of those grants and funding opportunities is the ability to engage an ICB. So you might have an ICB that will partner with you to deliver that funding. So say it's a £500,000 fund, you might have a service that you're providing or a solution or a product. You might have partnered with an ICB. That ICB will be a willing test site for you. So that money will essentially enable your solution to be rolled out for free across that ICB. And what's asked from the ICB is engagement and evaluation. Often you'll have an external evaluation partner. So that would generally tend to be a better way to engage ICBs. But again, in terms of direct procurement, there are other routes where, as I said, trusts, primary care networks have independent budget responsibilities and spending opportunities. So that direct to market at a perhaps lower level and straight to the ICBs can often be a good entry point for testing your value proposition.
Okay, so what about NHS innovation accelerators? What can you tell me about those?
So the NHS Innovation Accelerator, of which there's one primary one, which is a national one, is very, very valuable. It's very competitive to get onto it, but I think if you look at the companies that have historically engaged with that program, they're ones that are still around and tend to have achieved quite a lot in terms of NHS market engagement and traction. Historically, it's been on a journey. I think it very much focused on, by nature of its name, accelerating innovation in the early stages. Whereas I was fortunate enough to be at the kickoff last year with Professor Steve Powis, who was very open in saying that, we have a lot of innovation. What we've really struggled to achieve is scale and adoption of that innovation. So a real focus last year in terms of the cohort towards perhaps slightly more mature companies that have local use cases that we can now look to scale across other areas within NHS England and beyond, was a real step change. That's not to say it's the only entry point. There are other accelerators. Just this morning, speaking to a colleague about the health innovation networks, which some have accelerators and programs. Yorkshire and Humber have the Propel program.
Okay.
And there are other examples with the Northwest Health Innovation Network, East Midlands having an Innovation Academy, for example. They can often be feeders into the NIA, so it really kind of sets companies up in a local way to then be able to have that focus on scale and adoption nationally. So you could almost see some of those Health Innovation Network accelerator programs as a feed into the NIA for those that are most advanced and best suited to the focus areas that we're seeing at the moment.
Okay, that's excellent. I wasn't aware of that. So tell me about NICE and its cost effectiveness modeling. NICE Digital Health Technology Guidance. Are you involved in that?
We do a little bit of that, and self-professed NICE are on a journey at the moment too. I think the early evaluation model that they looked to work through previously was partially successful, I think, by their own admission. I think lots of people reference Sleepio and Big Health, in that they were one of the first movers. Yet national reimbursement still doesn't exist for them. So I think without sitting on the fence, it was kind of like, okay, what's the point? If we go through all of
Mm.
these hurdles, it's quite strenuous, it's quite costly. There's no guarantee of national reimbursement at the end of it. What's the point? And I think that has forced NICE to rethink how they do what they're doing. I know they're not at the end point of their journey yet, but a lot more collaboration with the ecosystem in terms of if we are approving and putting our name to these types of solutions, there has to be a more seamless journey for them to achieve commercialization, or the risk is companies just won't engage with NICE because, again, what is the point? So I think that in particular as a space is one to keep an eye on, because NICE, as I said, aren't at the end point of their journey, and there isn't a seamless pathway of engaging with NICE, following all of the processes, collating the right evidence, engaging with the system, and then being commercialized to the scale that you'd expect for the amount of time and effort and energy you're having to put into that process.
Okay, that's a very good explanation of it. Tell me, private insurers like Bupa and AXA, they are exploring digital solutions. How does that work in the UK?
They are. I think it's important to set the scene for this a little bit. Prior to COVID, the private medical landscape was very, very different to what it is now. My role at AXA, which is started a decade ago now, so we're rolling back the years a little bit. The majority of our funding for the wellbeing programs came from rebates and kickbacks from the insurance schemes that weren't fully utilized, and that could be to the tune of tens or hundreds of thousands. Of course, COVID happened, and now the utilization of private medical insurance has gone through the roof. Premiums have doubled, and somebody kind of alluded to the fact that what we've actually seen is not a great deal of transference from one private medical insurer to another, because the premiums across the board have gone up. So actually, how do they differentiate? And more critically, in relation to digital health, how do they reduce claims? A desperate need for private medical insurers to reduce the claims that they're seeing. So digital health technologies that can speak that narrative are very, very attractive. but equally digital health and software technologies that can help to differentiate some of those providers. I mean, we look at the likes of Vitality as a big disruptor in the market, very much focused on younger people, engagement, rewarding healthy behaviors. I think their most recent ad is, by engaging with for people that have their life insurance policies, engaging with Vitality and going from no activity to a certain amount of activity can add up to 5 years to your lifespan. It's a very different space now than where it was 10 years, 5 years ago. So I think one of the common mistakes we see with companies that think they can just enter private health care, private medical insurance as a partnership perspective, employee assistance programs, cash plans, and the likes, is that, they've all got lots of money, so it'll be a much easier route and we'll get more for it, we'll be more profitable. And it's really not the case. You still have to go through a process. They're historically slow moving. The return on investment model that you need to be able to show is still quite robust. You still need to be speaking to their language, and their language is very much on claim reduction as opposed to, often clinical outcomes or patient outcomes or engagement with services. And that narrative also has to change depending on if you're speaking to the procurement business commissioning folks versus if you're speaking to the clinical leads, key opinion leaders. So it's still a fairly challenging landscape to enter, and not one that can just be picked off as a second choice because another market's not paying what we wanted it to pay.
Okay, so most importantly, I think let's talk about Quiddity, what you do at Quiddity, and how it helps a digital health company. But I'm a digital health company. I knock on your door. What happens then?
Yeah, so we say we're about 5 years old, co-founded by two chaps that were the lead sales folk at Cinetech. So very NHS market engagement, scale and adopt across the board. They saw an opportunity for digital health companies and actually helping them navigate the system. I think there was a big challenge that, particularly with new entrants to the market, that companies were failing, not because they didn't have the know-how, or they didn't have the product, they didn't have the evidence base, but actually they just got caught in the complexity of the NHS and the UK market in general. So it was really to create a bit of a consultancy. What was realized very, very quickly is that the value isn't necessarily in the consulting. There are lots of people that can tell you what to do. There aren't many people who can do it. So actually we built quite quickly a sales team that could activate those plans and those strategies. So as we sit today, we're a headcount of around 30 people with about 20 senior advisors on top of that. Generally all salespeople who are, everything from account directors, senior business development team, to sales development reps, market engagers, growth specialists, however you want to determine that roles. So what do? We work with kind of startup to scale up companies who have the UK as a market focus for their business, and we do everything from initial market access and strategy. So actually, is the UK even the right market for you? Based on how your business set up, your funding, your investors, your focus, your runway, all of those factors, is the UK the right place for you to land or not? One thing we say with the UK market is it is very consistent in terms of the slow-moving nature of its reimbursement pathway. So often people come to us and say, we've got 6 months runway, what can you do? And sadly, the answer is not very much, because of the nature of what we know with the market. But that's one end of the spectrum. The other end is that we're the entire UK sales and commercial team, even expanding to mobilization, project management, implementation, customer success teams for a number of our international clients in particular. So instead of, building out a team in the UK, you can outsource that entire function to us. We operate as an extension of your internal organization. We have things like email addresses, presence on social media, all of that kind of stuff. But you get access to our expertise, our contact base, our know-how, in terms of commercially accelerating your route to the UK market, whatever that might be, whether it's the NHS, whether it's local authorities and government, whether it's health and social care, whether it's private hospitals, private medical insurance partnerships, cash plans, any of those different potential markets. We'll work with you to create and define that strategy, but then go and mobilize and activate that strategy through market engagement, pipeline building, growth, negotiation and contracting, and hand over to essentially successful delivery of those opportunities.
Oh, fantastic. I know people who've worked with you and they speak very highly of the organization. Tell me, it's not just healthcare you operate in, it's other areas, isn't it?
Yeah, the main focus is healthcare. Probably about 75% of what we do is NHS market engagement. It's the biggest potential reward for customers, but equally it's probably the most challenging to navigate. So We are a very responsible organisation in trying to find the quickest right opportunities based on what those companies' needs are. If that broadens beyond our areas of expertise, we're very fortunate in that we've got a very good partnership base of regulatory partners, investors, company or organizations like the Health Innovation Networks who have different value propositions to ourselves, but equally the import and export agencies. So again, if the UK isn't necessarily the right or the right country, the right landing point for some of the organizations we're working with, where else is the right place? Is it Germany with the DIGA as it exists today? Is it out in the Middle East? Is it the US market and all of the requirements that come with that? So it's making sure that we we'll give the most support we can to the companies as and when we get the opportunity to work with them. But most importantly, it's the success long term of those organizations. And if that's not with Quiddity and with the UK, then making sure they land at a point where they have a viable future.
Well, Tom, I'd like to thank you very much for your time today, and I've enjoyed it immensely and learned a number of different things about digital health in the UK, and I wish you all the very best for the future.
Thanks, Stephen. Appreciate it.